Thank you guys so much for coming out. I was going to say this thing about coming out in the rain, but it's not raining for the last 5 minutes, so we're okay. I'm Katelin. I've been a Cedardale member for a while, and I love seeing familiar faces from our Cedardale family. I brought my own family. I have my mom. And I am just so overjoyed to talk to you tonight about things that are really I'm passionate about, women's midlife health and metabolic health. So we'll dive right in. Hello to everyone who's watching this virtually. It's nice to meet you. All right. So for disclosures, I don't have any. No one is paying me tonight to stand up here and give this presentation. But what I hope that you get from this presentation is you leave feeling empowered, because I am a licensed healthcare clinician, but I'm not your licensed healthcare clinician yet. So that being said, I want you to leave here feeling like you can have a conversation with your care team and know what you think is best for you, because you are the expert in your own body. And if you have questions, like Mary said, I have a ton of content in here, so we're probably not going to have time for a huge Q&A that ends right at 7. So I will stay after and I'll answer any questions you have. If you're not comfortable asking me questions in a forum like this or in person, if you scan the QR code on that piece of paper, it's going to take you to a Google survey. Please fill it out, because that's how I know how to change this presentation in the future. That's why this one's a lot longer than the last one, for some feedback I got. So the feedback is helpful, and then you can ask me questions there and I will answer those questions for you. Okay. All right. So today we're going to try to cram a lot of information in, but I hope it feels, accessible and easy to digest. We'll start with some overviews. I'll give you an example of a clinical case. And then we're going to take a lot of time talking about the impact of menopause and perimenopause on metabolic health. And I'm really going to spend some time on talking about hormone therapy. So what it actually is, why is everyone so excited or afraid of it? Why have you not heard about it until, Oprah is giving menopause a moment right now? We've all heard that. So I hope you get a lot of information from this. So let's lay some groundwork here. We know that women are half the population in the world, but I think it's important to wrap our brains around the fact that 100% of women who live long enough are going to go through menopause, right? When we think about the amount of time and research and money that goes into things that are unique to women, like pregnancy, for example, not every woman becomes pregnant, and we live a sliver of our lives in pregnancy. Right? Hopefully, everyone in this room is going to spend 40, 50 years after their menopause living in a postmenopausal state. So it's really important that we're taking the time to educate women now so that they can be prepared for what life feels like in a postmenopausal state. And picture 5 years from now. We know that women of menopausal age are the largest growing demographic group. So 5 years from now, there'll be 1 to 1.2 billion women in menopause or entering menopause worldwide. And the CDC estimates that 1 in 2 adults are going to have obesity. So we're talking about people who are midlife with overweight or obesity. So that's why we really need to address it now, because it's affecting so many of us. Okay, so this is a clinical case. This is Elle. She's so pretty. So this is something that I would typically see as a primary care provider. I saw Elle back in May of 2023, and now she's in to see me today. The chart on the left are the vital signs and the pre-visit laboratory work that's done at a well visit, like a preventative care visit, your physical. On the right, you'll see what's the range of normal or healthy, and then you'll see what L's numbers mean when it comes to diagnoses. So it doesn't take a healthcare clinician to realize something is going on. So when I saw Elle in 2023, she was 46. And there really wasn't much to talk about. She had mild overweight with a BMI of 26, but her other markers looked really good. I mean, her abdominal circumference was okay for her ethnicity and her age and her gender, and her blood pressure looked good and her blood work looked good. And then 2 years later, it's like, what happened? Who is this person? Because her weight changed. It went up about 10 pounds, which took her BMI from mild overweight to moderate overweight. Her blood pressure went up. And that bottom number is consistent with stage 1 hypertension. That's pretty serious. That's not just saying this is kind of a elevated reading. Her bad cholesterol went up. That's that LDL. So now she has hyperlipidemia, which is high cholesterol. And anything with an asterisk is a healthy range based on this patient and her risk factors. Okay. Her A1C, which is her average blood sugar reading, went from being normal up to having prediabetes. And the medical assistant screened her for mental health concerns. So you'll get these little questionnaires asking you about depression and anxiety. Well, now she has moderate depression and moderate to severe anxiety. And her waist circumference, because I had my medical assistants check circumferences on all my patients, we know that your weight alone doesn't tell us too much about your health. So unless you're on a body composition scan, like I have now in my clinic, or like we have at Cedardale, the in-body, you're really not getting too much information with the weight itself, but the waist circumference can be helpful to assess metabolic risk because it's looking at visceral or tummy weight. And her waist circumference is up to the point where it's, increased risk. So not only did I see that there's something going on, but look at this laundry list that Elle mentioned to the medical assistant before I walked in the room. This doesn't sound like a well visit anymore. And I don't typically read from slides, but if you just listen to it as a laundry list, it's like, wow, low energy, trouble sleeping, night sweats, urinary frequency, weight gain, heart racing, muscle, joint pains, dry skin, painful intercourse, irregular periods. And I've got like 25 minutes with her. So what do you do? What's a PCP to do? Well, before I pursued advanced education in obesity and midlife health, menopause, and earning certifications through them, that was me up there like, oh, something is really going on. So your typical PCP will do the best they can to address her concerns, right? How many times have you heard, maybe not you, but has a loved one said, oh, I went to see my clinician and all they told me was to eat more salads and to try yoga and to, take some anti-inflammatories. And how about this for the poor sleep? Turn off my screens, maybe try melatonin. Or how about for the heart racing? Well, it seems like you're feeling pretty stressed. Look at those anxiety scores you gave me. Why don't you work on stress management? And if you limit your caffeine, maybe you'll sleep better at night and maybe you won't have so much urinary frequency, right? This stuff all makes sense, but the timing of it all and the fact that it's all happening at once, right? And how about the painful intercourse? Oh, that wasn't addressed. Come on. It's internal medicine. She would have been referred to her gynecologist because, that's not something we address in internal medicine, right? Bogus. Yeah. So, what were Elle's diagnoses today? It wasn't just preventative health visit. This is the patient who ended up getting that darn copay when she thought she was there for a physical. It's because she's got six new diagnoses today: overweight, hypertension, high blood pressure, hyperlipidemia, that high cholesterol, prediabetes, insomnia, moderately severe anxiety with moderate depression. And you say, Elle, well, what are we doing here? What's the thing you want to focus on the most? And she says, if I could just improve my mood, I feel like if I could be less anxious, if I could sleep better, I feel like all these other things will get better. And that sounds reasonable, right? So we say, okay, well, we're going to work on weight management. And the astute clinician might even check additional labs. She's kind of tired and having trouble with her weight, so maybe we should check a thyroid. She's having palpitations and she's tired, so maybe we should check a blood count, maybe check a urine because she's having urinary frequency. So we'll check some labs. And then Elle decided at this visit she wanted to start an antidepressant. She wanted to start Prozac. It's been around forever. It's a common SSRI used for people for anxiety or depression. So this was all pretty routine. This seemed like a really comprehensive, good visit. And the plan was to follow up in 3 months for a medication check, and then follow up in 1 year when we would repeat her laboratory work after she's worked on weight management and check that blood pressure again. Okay. Wow. Look at Elle's toolbox, right? Look at all these things: prescription medication, over-the-counter medications, lifestyle changes, referrals, blood work. Is there another explanation? Like, we all know this, that's why we're here tonight, but what if that visit had been different? Like, what if Elle had met someone that day who could have said, hey, this is what you're talking about is okay. This is normal. We can address this. We can get behind this. And I can explain why you feel like you're broken, because you're not, So, and that was really personal for me too, because I've been practicing primary care in this area for 15 years. And that would have felt like a really good visit to me 5 years ago. And now it doesn't, So let's do some basic definitions here, talking about what menopause even is. So I think it helps to start with what premenopause is. And premenopause is the time from menarche, which is your first menstrual period, to the time when you hit perimenopause. Okay, well, what's perimenopause? And perimenopause is this long arrow on the bottom of this chart here. It's a transitional time. So it's when you go from being a premenopausal woman to a postmenopausal woman. What's menopause? Menopause is one day of your life. The diagnosis or the explanation of menopause, yeah, right? It's 365 days since your final menstrual period. It's one day. So I saw, someone very recently, about 30 minutes ago, when I said, are you going to come to the presentation? And she said, oh, I'm done menopause. And it's like, well, yeah, you are, but you are in postmenopause. And I think that piece gets missed. We're never done being a postmenopausal person, because once we experience ovarian failure, there's nothing that flips those switches back on where all these things that happen at the midlife change suddenly go away. Does that make sense? Yeah. Okay. And then postmenopause is 12 months after the final menstrual period. And that's the next 40 to 50 years of our lives. So the timing of our menopause is really important to understand. And this is because early menopause, so menopause that happens before 45, and premature menopause that happens under the age of 40, increases the risk for really serious health conditions to happen to women. Women who have bilateral oophorectomies, that means women who have their ovaries removed, or women who have treatment for cancer where they get thrust into an early menopause, those women are at very high risk for things like heart attacks and strokes and cancer and early death, osteoporosis, dementia. So the standard of care is to offer those women hormone therapy. Wow, that sounds really important when we think of it that way. So why is it not important if it happens 5 or 10 years later, right? Okay, so timing is important. And I love this chart because the solid lines talk about your estrogen and your progesterone, which are the hormones that are made in the ovaries. And the dotted lines are your pituitary gland hormones. Those are the ones that are made from a part of your brain, and they tell your ovaries what to do and how to behave. So premenopausal women, yeah, there's a lot of fluctuation, right? But it's cyclic, and that has a purpose. That's for fertility, right? We need these beautiful ups and downs in order to be able to have normal cycles. And a postmenopausal woman, well, that's easy. I mean, I can close my eyes and tell you what someone's blood work is going to look like. Your estrogen and your progesterone are going to be in the toilet. And that's because your ovaries are not producing those hormones anymore. So when someone who's very clearly postmenopausal is like, I think I need to check my blood work. It's like, well, that's what it's going to look like, but okay. What's getting missed here is perimenopause. And again, that's this really gradual transition. We saw how long that line was. This lasts years. And when women are in perimenopause, it doesn't mean that they're skipping periods and they're like, oh, duh, that's what's going on. Perimenopause, the first sign of it when it comes to menstrual irregularity is just shortened cycles, maybe by 3 to 5 days. And that can be kind of hard to notice if something is still happening every month, even though it might be 3 or 5 days different. It's not until women are skipping at least 60 days between their periods that they're in late perimenopause, and they're probably going to stop menstruating within the next year or so is the average. Okay. So, and there's menopause. There's that one day. Menopause. So I really want to focus on the perimenopause to postmenopause transition, because in perimenopause, it is chaos, right? And that's why poor Elle feels like her body's broken because her hormones are just completely wackadoo. And this is the time when we see the most, we lay the groundwork for the most disease to occur. And that's because there's these really wild fluctuations in hormone changes that can lead to tissue modulation, which I'll explain what that means here. So what is actually happening? So my disclaimer is we're going to be talking about estrogen today because estrogen is the primary or the dominant female sex hormone. But that's a horrible way to describe it because these are human hormones. So whether we're talking about estrogen or progesterone or testosterone or cortisol or insulin or just, thyroid stimulating hormone, those are human hormones. So it's not just female hormones, but this is the one that does most of the heavy lifting for women. And to call it a sex hormone really like puts it in this tiny little box, right? It's only called a sex hormone because of the structure of the hormone. It doesn't mean that it only impacts sexual organs, and we'll talk about that in a moment. But so estrogen is the most dominant sex hormone for women. And the purpose of this hormone, or all hormones really, is to create some sort of target effect in the tissue or the cell that the hormone binds to in a receptor. So you can picture hormone functioning kind of like the Wi-Fi in your house, right? You have a router that sends a message to your phone or your laptop, and over that long distance, you're able to give a message. Well, that's exactly how this works in the body. If you look in the middle here, you're going to see that there's more than one type of estrogen. What? Yeah, I know, it's weird. So what we're talking about in this presentation is estradiol, which is it's the prominent hormone in premenopausal non-pregnant women. That's the one that's made in the ovaries. That's what we're talking about with menopause and the cessation of fertility and turning off of ovarian function. But we have estrione, which is the most dominant type of estrogen in postmenopausal women, which is actually made in our adipose tissue, our fat tissue. Remember that, because I'm going to bring this up later. And then we have estriol, which is the type of estrogen that's dominant during pregnancy, which is made in the placenta. So I wanted to show that because if you look on the left, we can see that all of these hormones are derived from cholesterol. And cholesterol gets such a bad rep, right? We're always talking about like, oh, I want to lower my cholesterol. Well, cholesterol isn't always a bad guy. You need cholesterol. You need it for hormone synthesis. And I also want to point out there, see, can you guys see testosterone? It's kind of like the bottom right. Look how testosterone is the precursor for estradiol. That's cool. So estradiol is also made from estrione. That's the stuff that's made in the adipose tissue. Oh, that's kind of making sense. So if women have more adipose tissue, they're producing more estradiol later in life. Okay. And women who are in their 20s have 4 times the amount of testosterone than they do estradiol in their bodies. That's kind of interesting too when we think about it being human hormones. And this chart on the right is a pretty basic description of how this feedback loop occurs, where the brain tells the ovaries what to do. So we start with the hypothalamus, which is a little part of the brain, which gives a signal to the pituitary gland, which I realize looks like a part of the male anatomy that we're not addressing today. I promise that's a pituitary gland. And then the pituitary gland talks to the ovaries, and then the ovaries send signals back to the brain. So that's why when we think back to that funky premenopause chart, that's what's happening here. Okay, so we talked about estrogen binding to receptors. So where are those receptors located? Spoiler alert, they're located everywhere. We have estrogen and progesterone receptors on nearly every cell and tissue type in our body. The picture on the right is a very oversimplified view of some of the areas where estrogen plays a role. And it's important to remember that where estrogen binds, it could have a different role. So estrogen functions in a lot of ways. It changes tissue. When it touches blood vessels, it makes blood vessels dilate. When it touches our liver, it works on cholesterol synthesis and blood clotting. When it touches our brain, oh my goodness, look at that beautiful brain over there that I blew up. There are so many receptors for estrogen and progesterone in the brain, and each part of the brain is going to have a different response to not having that estrogen bind to it and tell it how to behave. Our frontal cortex, which is our executive functioning and our ability to focus and concentrate. How about the hypothalamus? That's that part of the brain where we not only talk about temperature regulation, but we talk about energy and metabolism and our sleep-wake cycle. You can see why even the cerebellum, that's where your balance comes from. You can see why women are like, oh my gosh, like I feel like I'm going crazy. It's not you, it's the fact that you're not getting the hormones to your brain that it's been used to having for all these years. So does that make sense? Okay, so I know this is a busy slide, but that's because this is a busy time and Elle is not making it up. 75 to 80% of women are symptomatic from the perimenopause to menopause, really postmenopause transition. I don't like to read slides, but you can see that, like we said, the laundry list that Elle had is just a fraction of other things that could be going on. The ones on the left that I've put in bold, those are and this will come up later, but those are the FDA approved reasons to take hormone therapy. That's a pretty short list compared to all these other things. So yeah, nearly every tissue type, a myriad of concerns that are happening. Okay, so this is when we get real for a few minutes here. If you hear anything from me today, other than the fact of all the jokes I'm going to make, and you guys are going to remember that, there's so much more to menopause than hot flashes. And to have a clinician tell you to dress in layers or to turn the fan on in the bedroom, you are ignoring the fact that having a hot flash is a physiological event that has to do with your heart. When you have a hot flash, you're experiencing an increase in heart rate. You're experiencing an increase in blood pressure. And over time, women with severe hot flashes have changes in their brain that are like mini strokes. And women who have severe hot flashes are at higher risk for cardiovascular events than women without them. So we're not just like keeping your bed partner happy at night. We are literally reducing your mortality risk by considering treating your hot flashes. Okay. So when I think of female midlife risk factors or things that affect women disproportionately compared to men, I kind of group them into like 5 categories to kind of keep it simple. So we have cardiovascular disease. So I should probably just lay the groundwork by saying this. Women die of cardiovascular disease more than any other cause of death, period. The number one cause of death in women is cardiovascular disease, heart attacks and strokes. I know that's not the purpose of this presentation, and that's why I blew up the box of metabolic disease, but I couldn't sleep at night if I didn't say this. So women are more likely to die of cardiovascular events than any other cause of death. And it's fascinating because I wanted to make sure I got this right. More women die from cardiovascular disease than the next 5 causes of death combined. That includes cancer, right? We put so much emphasis on breast cancer in women, but it's our hearts that we and our blood vessels that we need to worry about primarily. So cardiovascular disease is really important. And there's a 4 times increased risk of cardiovascular disease in women in the 10 years following their menopause. Is that because all these women started smoking and eating McDonald's and sitting on the couch all day? No. That's because there is tissue changes going on that's affecting how their blood vessels work and how they make cholesterol, and it affects how their heart works. So this is really important stuff. I'm not going to harp too much on it, but so we have cardiovascular disease, but we also have frailty. That's such a horrible graphic, but I don't know. Thank you, Canva. I found it. So what do I mean by frailty? I mean that women are disproportionately affected by sarcopenia. Sarcopenia is muscle wasting. And muscle wasting and osteoporosis, which is another risk factor for women at midlife, they lead to brittle bones. And that leads to the woman who trips and falls and she breaks a hip. And if she survives that, then she gets hospitalized. And if she survives that, then she goes home. And if she survives that, she's got limitations and she's got disability, right? So it affects morbidity, like quality of life, not just mortality. So cardiovascular disease, frailty, cognitive disease. I'm not just talking about mental health concerns like depression or anxiety or insomnia. We know those disproportionately affect women. I'm talking about neurodegenerative disease, memory loss. Alzheimer's disease is primarily a disorder of women, not just because we outlive our male counterparts. It's because there's something structurally going on in the female brain that's different from the male brain. And we know that that risk is increased in women who have an early menopause. That's something to think about. Okay, so cognitive disease, sexual dysfunction. I love to talk about sex health. I think it's so awesome. I don't think sex is extra. I think it's a part of the human experience. And we know that our sexual health is disproportionately affected for women, whether it's libido or the ability to orgasm or intercourse being painful and the genitourinary syndrome of menopause. So that's another bucket that I would love to explore at a different time when we don't have such a time crunch. But today's topic is about metabolic health. So what even is metabolic disease? It's an umbrella term that describes disorders that have impaired ability to process food or for energy. So it includes things like obesity or excess abdominal weight. So that's L's increasing waistline. But it also includes precursors to diabetes like insulin resistance and prediabetes. It includes high cholesterol, high blood pressure, liver disease like fatty liver, which is now, steatosis of the liver or metabolic associated steatosis of the liver. They're always changing the term for it. So lots of things to talk about with metabolic disease. And I just want to highlight that although obesity is a disease, I love to give presentations on this too, and the obesity epidemic is affecting men and women, women are disproportionately affected by the insulin resistance, and we have more cases of diabetes and more severe obesity than our male counterparts do. Okay? And there's something that's happening with this midlife hormone change. Let's see. I want to make sure I got everything that I wanted to talk about with that slide. Okay, so enough, Katelin. Talk about weight gain. Validation. You're not making it up. There is 60 to 70% of a chance that women are going to develop weight gain at midlife. Now, how much weight gain? Because that's kind of where it gets dicey. The amount that the scale actually changes is not as much as you would think or you've heard about from your girlfriends or your mom or your loved one or whoever it is. So the average weight gain is about 1.5 pounds a year. But you think of perimenopause, right? And that might last 5 years. And this weight gain tends to slow down 2 years after your final menstrual period. So maybe that person has gained 1, 3, 5, 10 pounds, like Elle had that 10-pound weight gain. And that was a big shift for her. So it's not necessarily the scale going up, but it's where the fat is being collected. And what's happening is that abdominal obesity or fat that collects in our midsection, that risk increases 5 times it's a 5-time increased risk for a postmenopausal woman to have central obesity than it is for a premenopausal woman. And there's a lot of things that go into that, but I've tried to simplify it, at least with 4 different big things that are happening. So why are women gaining weight at midlife? Well, we talked about reduced muscle and sarcopenia. Your muscle, your lean body mass it's really the driving force or the biggest predictor of your basal metabolic rate. That's your resting metabolism, the amount of calories you need as a machine to burn if you just sit on the couch all day, just for cellular function. It doesn't include your exercise or your non-exercise activity. So skeletal muscle is essential in your peripheral control of your metabolism. But there's also a central effect of reducing your metabolism on your hypothalamus in your brain. So we talked about that picture of the brain and how the hypothalamus is really important in energy regulation. So you kind of lose the integrity of your energy regulation in your brain, and it can lower your daily caloric burning by 200, 300 calories. That's a lot. We should acknowledge that. And even more, in the brain, you kind of get a loss of hunger suppression. So estrogen suppresses hunger, which is kind of interesting. We know a lot more about hunger now that medications have come on the market that talk about how hunger is a driving force in your brain. Well, estrogen does play a role there too. And then finally, we get this shifting of adipose storage to our midsection. So that premenopausal woman who was, pear-shaped becomes a postmenopausal woman who's more apple-shaped. And if you think back to that very first moment when I'm like, remember this about postmenopausal women having their dominant form of estrogen being made in adipose tissue. So there's a pretty strong theory that Mother Nature did this on purpose to us. Ugh, how rude. But if you think about your router, if you have to move your router closer to your essential organs because the kind of estrogen that you're producing is not as strong or effective as the estrogen that used to be made in your ovaries, she kind of did us a favor in that, right? Because we still need postmenopausal estrogen, but the kind we make doesn't work as well. So she's like, cool, let's have it in our midsection. And then they actually change the ability for the adipocyte, the cell that stores fat in our visceral adipose tissue, that kind that's around your tummy and your organs. Those cells get bigger and they can store more energy. So you're even better at storing energy in your midsection. So that's a lot. And she looked so unhappy. So I hear her. So what's up with menopause and diabetes? Okay, we know that there is increased risk of insulin resistance, and insulin resistance is the precursor to diabetes. But we should probably pause for 1 minute and make sure we're all on the same page about what insulin is. So insulin is a hormone. This hormone is made in your pancreas inside these beta cells. And the purpose of this hormone is for sugar or glucose regulation, right? So women at midlife have an increased risk of developing type 2 diabetes, and that risk increases the younger they have their menopause. So you can see this poor little pancreas who's just like crying because our pancreas is getting tired over time. So your pancreas is having to churn out more and more insulin to keep up with hyperglycemia or high blood sugar levels in your bloodstream. Okay. The flip side of that, we're developing resistance to insulin in our periphery. So that means cells like in your muscles and in your liver, they're not responding as well to that insulin hormone that they used to. So now your insulin has to work even harder to keep those normal blood sugar readings. So you get a phenomenon called hyperinsulinemia, which basically means you have high levels of insulin in your blood, even when your blood sugar test is normal. So when Elle saw me with that elevated A1C, she had already had insulin resistance going on way before that, maybe even decades before that. But her pancreas was working so hard, it was able to keep up with that demand for insulin. And then once you start to experience prediabetes, well, it's kind of a downward slope toward diabetes then. So we have reduced insulin secretion. Your pancreas just kind of gets tired and those beta cells are not as productive as they should be. We have reduced insulin sensitivity. That means the cells that insulin is trying to bind to, it's not working as well there. And insulin and adipose tissue in your stomach, so visceral adipose tissue is more resistant to insulin than muscle is. And we know that you're already losing your muscle mass from that phenomenon too. And then your little liver who's like, help. There's a phenomenon called gluconeogenesis where you're able to make sugar from non-sugar foods. We get better at that. Awesome. So now your liver is making sugar out of non-sugar foods. So that low carbohydrate style of living that you were on in your early 40s, which was like you were killing it. Now all of a sudden it's not working as well. And you're like, ugh, I didn't do anything differently. You may not have, but your body is metabolizing things differently. Yeah. So, oh my gosh, Katelin, are you going to tell us bad news the whole night? This is awful. Well, there's good news. And I'm not the first person to think of it. So what is hormone therapy and why was it so popular and why is no one using it anymore? So the first hormone therapy was actually made in the 1930s, but its indication was not for menopause. It was for painful periods. In 1942, the FDA approved Premarin. Premarin is, we still use it today. It's a medication used to treat hot flashes. And I love this ad that I found. It's from 1953. And I know you probably can't read it, but it says, complete relief of symptoms was experienced by most menopausal patients. It was called highly effective, well tolerated, and imparts a sense of well-being. That's why she's so happy, because she's on Premarin. So what happened over the next 50 years? Well, the use of Premarin skyrocketed. And by 1992, Premarin was the #1 prescribed drug in the United States. Holy cow. So it comes out in the 40s. Birth control didn't even come out till the 1960s. So women are loving life. And ads like this are going out telling women, you don't just take it for your hot flashes. You actually take it because you can prevent aging. You can prevent dementia. You can prevent heart attacks. You can prevent a loss of femininity. I love that one. So it helps with their sexual health, right? So what happened? Well, how did we go from that to here? The WHI happened. Now, the Women's Health Initiative is not all bad news. But when you hear someone talk to you about why hormone therapy is dangerous or not recommended, they're probably referencing some sort of information from this. So what the heck was the WHI? The WHI is still to date the largest randomized control trial that we have on women. So what is a randomized control trial on postmenopausal women, pardon? A randomized control trial is the best type of research we can do. And what it was it was supposed to be this longitudinal study that looked for preventative interventions we can do so that women, postmenopausal women, aren't going to get serious diseases. And the diseases they wanted to look at were cancer, so breast cancer, colorectal cancer, osteoporosis, and heart disease, because we know that affects women later in life, right? So they actually looked at 3 different types of interventions, even though we only talk about the hormones, but they looked at calcium and vitamin D replacement, they looked at low-fat diets, and they looked at hormones. Okay, when they looked at hormones, they separated women into 4 groups. Now, it's common knowledge that when women have a uterus and you take estrogen, Estrogen thickens the lining of your uterus. So if you have a uterus, you need to take progesterone to balance out that overgrowth of estrogen, because if your uterus gets too thick, there's a chance you can develop endometrial hyperplasia, which could lead to endometrial cancer. So we mitigate that risk by putting women on progesterone. So if you have a uterus, you need to take progesterone with your estrogen. Okay, so here are the groups. We had women with a uterus who were given hormone therapy, which meant estrogen, progesterone. And then we had women with a uterus who got placebo. And then we had women without a uterus. Those were our patients who had a hysterectomy, who just took estrogen because they didn't need the progesterone because they didn't have a uterus. And then we had women who had a hysterectomy who took placebo. So 4 groups: uterus, hormone therapy, uterus, no therapy, no uterus, hormone therapy, no uterus, placebo. Okay, so this trial was supposed to go on for 8.5 years with a surveillance period of 13 years after that. But what happened? Well, in 2002, the estrogen progesterone treatment group, so uterus hormone therapy group, stopped the trial early. Like that's spooky. Well, why'd they stop it? They stopped it after 5.2 years because they found from the data that was collected and interpreted that these women were having really serious things happen: heart attacks, strokes, blood clots, cancer, breast cancer in particular. So everyone, and pulmonary embolism, so blood clots in their lungs too. So it was like, whoa, and like overnight, like women flushed their hormones down the toilet and doctors ripped up their prescription pads and they're like, hormones are bad. And I went through my medical training in 2009 to 2000, like early 2012, 2011. And when I went to school, we were told hormone therapy is used at the lowest dose for the shortest period of time because it causes breast cancer. That's what I remember. And I haven't even, was not practicing when women were on it. And it's kind of unusual to find a clinician now who may have been practicing while hormone therapy was still kind of the standard of care. So most of the clinicians you're meeting are in that mindset. You have to remember, I'm not trying to cut anyone's slack here, but menopausal medicine is not a part of medical school curriculum. This is something you have to, and that's not right. That's one of the huge gaps in our knowledge in medicine, just like it is with obesity. And I could talk to you about that for days. But we have to understand that your clinician that they're talking to was me, right? Unless you pursue this knowledge on your own, you're not taught it from either your mentor, who's terrified of hormones because they knew it was going to cause breast cancer, or they just never learned it, right? So the use of hormone therapy dropped. Okay, I spend a lot of time on this slide, and that's because the feedback I got was women want to feel empowered to have a conversation with their clinician on why they might choose to use hormone therapy. So bear with me. I know it's a lot of information, but I will try to break it down. So what were the limitations of the WHI? Number one, the outcomes of the WHI were reported as relative risk, not absolute risk. What the heck does that mean? Okay. Absolute risk is the number of people experiencing an event in a group. So if there are 100 people in this room and we're all sitting on chairs and 10 people fall off their chair while they're sitting on it, that means the absolute risk of falling off your chair is 10 out of 100 women. Well, that makes sense. The risk is still pretty low. We're probably still going to sit on a chair, but that was weird. I don't know why they fell off their chairs. That's the example I came up with for that one. Relative risk is a comparison between two groups. So what's the likelihood of you falling off your chair versus not falling off your chair? This is when things start to get weird, because relative risk is expressed as a percentage or X amount of times greater than or less than. It's often used to exaggerate results, really, like if you're trying to show that something really works well, or if you're trying to say something really doesn't work well, you can talk about relative risk. Absolute risk is much easier to not only understand, but also like to help you make a decision as to, is this actually going to affect me or not? So I'm giving a specific example here because one of the main outcomes of the WHI was about cardiovascular disease, right? So in the estrogen progesterone group, that's uterus hormone therapy group, the relative risk of having cardiovascular disease in that group compared to placebo was reported as 29%. Oh, that sounds really high, right? Like, oh, that sounds kind of spooky. But if you look at the absolute risk in the estrogen progesterone group, so in the hormone therapy group, was 37 out of 10,000 women, okay, versus the placebo group, which was 30 out of 10,000 women. Okay, so now the actual percent increase is 0.07%, or 7 women out of 10,000 women, which is not statistically significant. Does that make sense? I know it's a big thing to understand, but it's really important because we don't need to throw this data in the toilet, but we have to understand the limitations of it. Even more than that, the data that they interpreted, there's something called the confidence interval, which is how we can decide if something's significant or not. They didn't adjust the confidence intervals. And once this data was interpreted like a billion times later after the WHI came out and they adjusted the confidence intervals, a lot of the data wasn't significant anyway, even when you were talking about relative risk, not even absolute risk. Okay, so that was a problem with the data itself. Let's talk about who was actually in the trial. Did you know that women who were having hot flashes were excluded from this trial? What? Yeah, I know. This trial was not meant to say, does hormone therapy help with hot flashes? Duh, we knew that since the 1940s. Remember our happy woman? Yeah, no, it wasn't to prove if it worked or not. The purpose of this trial was to say, does this reduce the risk of serious things like heart disease and breast cancer, colon cancer, and osteoporosis? So women with hot flashes were excluded because if you gave them estrogen progesterone treatment, they'd be like, oh, great, I'm on the treatment arm. And then you lose kind of the double blind effect of knowing whether or not you're on the treatment. So you take symptomatic women out of it, but that means that the average age of the woman who was in that trial was 12 to 15 years past her final menstrual period. So this was a trial based on older women. Less than 30% of the women in this trial were under the age of 60. That's important to remember when we talk about who should take hormone therapy going forward. So we took this big group of women who already had cardiovascular risk factors, right? They were older women. And what did we do? Well, we gave them one type of estrogen, oral, and progesterone, one type of therapy. We didn't give them patches. We didn't give them creams or gels or something topical like local that we prescribe today. And we only gave them one type, which was synthetic hormone. Estrogen was the conjugated equine estrogen. And the progesterone was MPA, the medroxyprogesterone acetate. And these are pretty high doses too. I put a picture of it. See, it's still around, but this is like the third out of 4 doses, like the third step out of 4 doses you can take for PremPro. That would be a pretty high dose for the average person to be on hormone therapy now. And so they took these older women, put them on high dose oral hormone therapy, and then they slapped these labels on all types of menopause hormone therapy. So vaginal estrogen got the same exact risk profile. If you open up the package of vaginal estrogen and it's like may cause cancer, may cause strokes and heart attacks, they got that from the WHI, not because it's actually been documented. This becomes a class label. Does that make sense? Okay. And there was a high dropout rate in this study because imagine here you are, you're on year like 5 of your treatment arm, and then you get this letter in the mail that's like, as a side note, the treatment you're on might be causing heart disease, heart attacks, strokes, blood clots in your lungs, and breast cancer. And women are like, nope, I'm not going to participate anymore. And then they allowed women to choose if they wanted to be in their treatment arm or switch to a different one. What? Okay, so those are the limitations of the WHI. And I hope that this kind of helps you feel like you can have a discussion with your clinician when they start to reference it. You can say, wait, I know about this. So let's talk worst case scenario. We took a group of older women with risk factors. We put them on oral hormones at high doses. And then we said, well, let's see what happens. And you know what? Not much did. The absolute risk of having a complication was pretty rare. Like, again, absolute risk, not relative risks. The actual number of women, less than 10 out of 10,000 women a year. Okay. And we could see some trends from the data too. The risks are lowest in women when they're under the age of 60, and the risks are higher when they're older. And the risk was greater in women on the estrogen progesterone therapy than women who were just on the estrogen therapy. So this little Venn diagram, I thought I was so clever. The one on the left is the risk factor for women on estrogen therapy was endometrial overgrowth. That meant if they had a uterus and they just took estrogen, their uterus would get too thick. We already knew that. That's why we put women on progesterone, but that was the risk for women if they were to take just estrogen. Both estrogen and estrogen progesterone therapy had increased risk of blood clots, which is a big deal, and increased risk of gallbladder disease. No one talks about that, but estrogen causes gallbladder dysfunction. It causes gallstones and gallbladder removals. But again, the absolute number is something like 30 to 40 women out of 10,000. Okay. But that was true. And then the estrogen progesterone treatment arm, that's the one where the spooky stuff was found, right? Strokes, heart attacks, breast cancer. So let's explore that. Okay, don't be mad. I know this is data, but if you look at the top group is women who just took estrogen. The bottom group is women who took estrogen plus progesterone. Now, everything that's red is bad. Things that are blue are good or positive. If you look on the left, the line that's going up talks about absolute, not relative, absolute risk, the number of events per 10,000 women per year. Okay, so let's talk about breast cancer, because that's what everyone has heard, right? Well, hormone therapy is going to give me breast cancer. Okay, the absolute risk was 6 women out of 10,000 women. 6 women out of 10,000. Okay, let's talk about estrogen. Wait a minute, it actually got better? Yeah, 5 out of 10,000 women were less likely to have breast cancer when they took estrogen alone. Did that get reported? No. Okay, well, if it wasn't the breast cancer, what about all cancer? Yeah, women who took estrogen alone had a reduction in all types of cancer when they took hormone therapy. Okay, well, what about death? Well, yeah, women who took estrogen died less often from all causes of death. That seems kind of important. But what about progesterone? Because that's a bad guy. No, people who took progesterone still died less often when they took their hormone therapy. Yeah, I really hope that sinks in, because it's hard to interpret data. It's hard to interpret relative risk. And when the clinician that you trust is looking at you and saying, this is going to give you breast cancer, you believe them, right? But I want you to feel empowered. Okay. So what do? We have to balance risk and benefits. And the timing hypothesis is kind of the gold standard when a menopause expert will prescribe hormone therapy. And what it means is if you start treatment within 10 years of your final menstrual period or before the age of 60, you're going to have the best outcome with the least amount of side effects. We even saw that from the WHI. If you use it later in life, it might be harmful. And that's, again, what we saw from the WHI. So if you are an older woman, should you use estrogen to protect your heart? Probably not if you already have cardiovascular risk factors. That might increase the risk of you having a blood clot in your legs and your lungs or a stroke. And if you try to take it to prevent dementia, that might be harmful if it started later in life. And if you're trying to take it for your mental health, well, it might be neutral. It's probably not going to help. And it makes sense because if you think of estrogen as being a morphogen, it changes the way tissue behaves. The longer it's been since your tissue has been bound to estrogen, the more time you have for that tissue to change and behave a different way. And then you give it a treatment that makes it change. Once it's already changed again, you could see maybe why that would be pathological, right? So it kind of makes sense. Okay. This is my own personal pet peeve. When you go to your doctor or your advanced practitioner and you tell them that you want to start hormone therapy and they start telling you that HRT is not right for you, I want you to be able to say, I'm not asking for HRT. There's a difference between HRT, which is hormone replacement therapy, and MHT, which is menopause hormone therapy. It's okay to call it all hormone therapy if you weren't exactly sure which one you want to talk about. But hormone replacement therapy is given to pre-menopausal women, and it's used to protect against early menopause. We talked about that. The timing of your menopause is really important. It's high-dose hormones. It's monitored by laboratory work because we want to get these women up to a premenopausal level of hormones till at least the age of 50 or 51, so we can prevent those early heart attacks and strokes and dementias and cancers, okay? Menopause hormone therapy is what we're talking about when we're talking about midlife women using hormone therapy. This is used to relieve symptoms. This is not meant to bring you back up to a level of premenopausal hormones. That's why these doses are lower, and that's why this treatment is safer. And we don't check your blood work because it's not, your outcomes are not driven by lab values, they're driven by symptom management. Okay. So you want to make sure you're asking for the right thing too. Okay. So what are we even doing about hormone therapy today? Well, there are 4 FDA approved reasons for it. And if you think back to that laundry list of what's happening during menopause, I had bolded that one for you. So menopause hormone therapy is the first line treatment for hot flashes that are moderate to severe in nature. It's not putting a fan in your room or dressing in layers or taking an antidepressant or taking gabapentin. It's hormone therapy. It's also used as prevention for osteoporosis, not the treatment of osteoporosis. Again, the longer it's been since your tissue has changed, since you received estrogen, you need to use other tools in your toolbox, although it can still help. This is to prevent osteoporosis. And it's also used for the genitourinary syndrome of menopause, which I could talk your ear off about forever, but that's basically the constellation of things that are happening below your belly button. You know, your vaginal changes, your vulvar changes, your bladder changes. This is why women get frequent urinary tract infections or feel like they have one. It's from GSM. And that's the first line treatment for it too. And then it's approved as HRT for that woman who needs early premature menopause protection. Okay. And if you look at the bottom, that's where it's like, oh man, so it's not approved for me to lose weight or make my hair thicker or make my skin more luminous or to, make my muscles grow better or prevent dementia. No, it's not FDA approved for those things. But could it help? Yeah. I mean, that's why we prescribe things off label. Did you know that birth control pills are only FDA approved for pregnancy prevention? Think of all the reasons why we go on birth control pills: for period regulation, for, hormonal control, like acne control, for our mood stability. That doesn't mean that we're doing something wrong. We're doing it off label, knowing that it can still be safe and effective and not FDA approved. Just to lay the groundwork there. So what could it be helpful for when it comes to metabolic health? Could it be helpful for obesity? Yeah, it could be. And we see when women use menopause hormone therapy at the time of your perimenopause transition, we're going to see less growth of your waistline. So we're going to see a reduction in visceral adiposity. Are we going to see people lose a ton of weight? No, it doesn't really work that way. It's not an anti-obesity intervention. But could this be preventative for someone who wants to make sure that they're maintaining their lean muscle mass and make sure that their waist circumference isn't increasing? Yeah, it might be helpful for that. What about for diabetes? Yes. When women take menopause hormone therapy at the time of perimenopause, we can see a reduction in the new onset of type 2 diabetes by 15 to 30%, depending on what meta-analysis you look at. And what about for cholesterol? I didn't even talk about cholesterol. It makes the good stuff better, makes the bad stuff lower. So, do you have any research to back that up, Kate? I actually do. So in April of 2024 in the Menopause Journal, there was this new research that was developed, that was published, that showed that postmenopausal women who were taking Wegovy, semaglutide, experienced a greater weight loss at 12 months than women who weren't taking it. Now that's, we could talk about a few limitations to this study. The sample size was too small. They only studied them for 12 months. But this is the kind of data that we need to start seeing to just kind of put into black and white what we kind of are seeing clinically or anecdotally with our patient care. Okay, so who can't take hormone therapy? It's not as many people as you think, and it depends on the type of hormone therapy. So whether it's something systemic, like a pill you take by mouth or a patch you wear, or if it's something you're putting locally, because local hormone therapy like estrogen cream, there's trace to zero systemic absorption. So that's a discussion to have if someone has active breast cancer, to talk with their oncologist about. But for the most part, there really aren't that many reasons why you can't. And I want to make sure everyone knows that there is no family history that will stop a person from being able to at least consider menopause hormone therapy. Okay. And that's a big deal. I can't tell you how many women come to me and say, well, I could never take hormone therapy because my mother's sister, mailman, had breast cancer and I can't take it. Well, that's not the case. And what are the adverse effects? Not as many as you'd think. Breakthrough bleeding? Yep. Just like kind of if you had started a birth control pill before and they kind of warn you the first few months, it might be a little wonky. You might get some bleeding outside of a cycle. That's normal. And it's so normal that we really don't even call it a side effect, but if it were to happen to a woman who's totally postmenopausal and she's on her hormone therapy and loving life, and then over 6 months into treatment, she suddenly gets some unexplained vaginal bleeding, she needs to be evaluated because we want to make sure she's not getting a thickening of that endometrium, the lining on the inside of her uterus. Other side effects, breast tenderness, yep. Nausea, bloating, yep. Not weight gain though. So if someone's afraid to start their menopause hormone therapy because it makes them gain weight, there's really no evidence of that. It's probably their perimenopause transition. And then maybe some mood changes. So what are the take-home messages here? So I hope that everyone has heard that perimenopause and menopause is more than hot flashes. This is a really important time when we're laying the groundwork for serious illness to occur, because menopause is not a disease. It's a natural part of a woman's, hormone transition, but it does kind of set the stage for serious things to happen. And we need to be on the lookout for those and know how to prevent them. And menopause hormone therapy is FDA approved for 3 reasons: hot flashes, GSM, and the prevention of osteoporosis. But there may be some off-label indications that it might improve other things like your metabolic health if you initiate it early enough. And there are safe and affordable, and when I say affordable, I mean like maybe $20 a month, not hundreds or thousands of dollars a month for GLP-1s like people want to take. Safe, affordable, FDA-approved medications that are both synthetic, like the ones we saw that were used in WHI, and bioidentical. I could have another whole presentation on what bioidentical means. But there are medications that are approved in multiple forms that you can take for long-term. And we know that women who start it earlier from the time of their final menstrual period do better. And for most women, the benefits of taking it are going to far outweigh the risks of not taking it. But the decision to start any sort of intervention, you have to have a discussion with your clinician. Okay. So here's some references. Thank you. I know I took a lot of time, but I'm happy to stay for questions, or like I said, you can scan this QR code. That's for you guys at home. You can scan the QR code and you can answer a survey and fill out a questionnaire for me. And I will get back to all the questions too. And if you are a Cedar Dale member and you want to hear me ramble on some more, you can come see me. So if you want to talk about having a consult, I have a discounted rate for Cedar Dale members. And a consult is just an opportunity to sit down and really talk about your risks, whether or not you choose to add me on your care team, because I want you to feel like you're leaving this presentation with a lot to tell your care team. All right. Thank you. Thank you.